Thank you very much for inviting me to this session today. We are broadcasting from the United States, and it is indeed my great pleasure to have put together a session with some of my colleagues and some very good speakers from across the US with Neuro Oncology. And so I will be giving a presentation on the uses of nuclear medicine, at least in imaging in neuro-oncology. I'm going to start my slides and share that with you. So for those of you who know me, I've been actually jumping around a bit. I am now at Kettering Medical Center in Ohio, where I'm the director of theranostics. And one of the wonderful things that I found here is an excellent neuro-oncology program that I will be talking briefly about, which I hope you find interesting. Okay, so in terms of disclosures, I have no particular disclosures except some of the stuff that we're doing here is not officially FDA approved, although we're doing it under special permission by the FDA. And I'm also very deeply appreciative of Dr. Martin Jacobs, who is my colleague in nuclear medicine. And since they've been doing imaging for quite a while in this field, he provided me the lion's share worth of the slides that I'm going to show you today. I'm going to very briefly touch upon what it is that we've been doing. Kettering Hospital is actually not itself an academic institution. We're just very much a run-of-the-mill community hospital. And I would say almost run-of-the-mill because one of the jewels that we have here is that we have a cyclotron program, a PET imaging program that is, even though it's a community hospital, it rivals that of some major academic centers around the country. Just to kind of give you a timeline of what's been accomplished here, after the first PET scanner was approved in 1985, that's the world's first PET scanner. Kettering Hospital was able to acquire a cyclotron facility and a PET camera by 1990. So within 5 years, they already had one. And I will let you know that everybody else, including all the other major academic medical centers, started getting their first PET cameras 10 years later, 2000. And there are certain medical centers that still don't have PET cameras in the US, surprisingly. But certainly Kettering has been leading the charge. And with the PET camera, they've done some fairly advanced research, a lot of it in the neurology side and neuro-oncology side. But upon my arrival, I have added on the theranostics aspect, especially now that it's taking off so much. So I'm really proud to be a part of the center. And what I will be doing is actually laying some very basic groundwork. So I'm going to be actually talking about some of the clinical stuff that we've been doing and setting it up for my colleagues that I have assembled together to go further into depth about with what our capabilities have been thus far. So in neuro-oncology, in terms of imaging, what is it that's really needed? We need to identify the malignancy, at least find out initially if we see a lesion, is it benign or malignant? Maybe is it infectious or is it really a cancer that we're looking at? Once identified, go through initial staging, and then we want to be able to treat the person with surgical, radiation-based treatments. And then once the treatment's done, if there's an issue of recurrence, figuring out if there's radiation necrosis or is it just scar tissue left over from surgery versus malignancy recurrence, that's an issue. And then some of the stuff that comes in the future might be molecular profiling of lesions based off of imaging. We won't be touching on that much as much today. I'm just kind of putting it out there as a general thought. So we were just talking about thallium imaging. Thallium imaging has been used ubiquitously in a lot of areas. This is a a case where a lesion was seen in the MRI and a thallium imaging was done to try to correlate the uptake, and there really wasn't much uptake, it was very mild uptake, showing that this is likely not malignant. It turned out to be a toxoplasmosis. And but of course, going away from SPECT, PET has become a much bigger issue in and player in this field. Now, most people are very familiar with MRI because of its high resolution and because of its superior aspects of being able to do surgical planning and radiation planning. You see what is there, and it gives you the great soft tissue contrast. But it is also understood that there's often non-specific findings that we see, and it may potentially under and overestimate the extent of the disease. FDG PET has come along, and there's been greater specificity with regards to PET. And we know that it picks up more aggressive sites of disease, but the problem with FDG PET has been there's been high background and signal limits, which limits the sensitivity of what we see on PET. It is lower resolution, and it still has some issues with inflammation, albeit it could be better than MRI. Now, most places, even though they have PET, Neuro Oncology tends to use MRI a lot, but I will hopefully show you where some areas where PET can at least add information, if not more. Here's an older case where there's some amorphous changes in the brain based on MRI and CT, and we can see on FDG PET that there's a little small focus of uptake in the right frontal lobe, which turned out to be an oligodendroglioma. So before they went in, they were able to find the tumor, localize it a little bit better amongst these amorphous changes, and also confirm that it's likely going to be malignant in order to do appropriate surgical planning. This is a case actually done with PET-MR, where there's a lesion after the patient's being treated with radiation, and the question is there radiation necrosis? An FDG PET scan was done in conjunction, so this is really a PET-MR rather than a PET and MR, and that those findings suggested that this was more akin to radiation necrosis because, again, the uptake was very mild, and that was sort of also confirmed with more advanced MR sequencing. This is a case where I did on PET-MR back when I was at the University of North Carolina, where we see a main lesion on the left side, which only has mild FDG activity, suggesting that that probably may not be a recurrence, but we see a much more avid lesion in the left occipital region, corresponding with the MRI findings, suggested that that is the malignancy that we would be much more concerned about and would need to biopsy and or surgically or radiation therapy. Likewise, here's a case where a PET MRI was done on a patient where we saw a lesion. There was a question of, is this a recurrence or not? And as we can see with the fusion, what happens is that only part of the lesion lights up. So that's very helpful because, again, part of it turned out to be necrosis, but we were able to localize that part of the lesion that was most active where they biopsied and confirmed that there was recurrent disease there. So if you can imagine, if you had just done the MR and they felt that, yes, this is going to be recurrent disease, they might have very well could have biopsied the wrong place and gotten the wrong information, not realizing that there was a nidus or recurrence within the area of necrosis, and the patient would not have gotten the appropriate treatment. But one of the things that we are doing here at, and we have been doing, as pointed out, since the early to mid 90s, and that's before the approval of PET, is the use of C11 methionine imaging. C11, carbon 11, has a half-life of about 20 minutes. C11 methionine is metabolized by transmethylation, and it is ubiquitous. It's found everywhere, and when given, it is rapidly incorporated into protein synthesis. And the usefulness is malignancies because there's increased avidity for methionine in a lot of tumor cells. It's known as the Hoffman effect. There's rapid uptake and metabolism into lesions. Given the very short half-life, that is very important that that happen. The good thing about methionine is that unlike FDG, that there's low background uptake in the brain. There is uptake there, but not much. In terms of whole body imaging, there's high liver uptake and it limits liver evaluation. It is liver renally excreted. There is some bowel activity as well, but again, over the time period we're imaging, that's not as such of a big deal. But there is higher uptake in many malignancies where there's lower FDG avidity. For example, in low-grade malignancies, methionine will have better uptake than, say, FDG would. And this is just one of the cases, one of the many cases my colleague, Dr. Jacobs, gave to me, where we can see that there's concordance of glioblastoma uptake on both the methionine and the glucose FDG PET imaging. And then you can see in the MRI, it is not as well seen, but you kind of look at it carefully, you can see where the how the images correlate with the MRI. This is a slide for fluciclovine, which one of the colleagues that I've talked about from University of Pennsylvania will be talking about today. But basically, amino acids have very similar ways of uptake into the cells. There are two transporters, amino acid transporters that are upregulated in malignancies, particularly LAT1 and ASCT2. LAT1 is the one that's primarily responsible for uptake of methionine into tumors. So give you another case where this is methionine uptake and FDG uptake and superimpose it onto MRI. You can see the MRI abnormality, but what you will see here that there's a significant discordance between the methionine and FDG uptake. So if we had only done FDG scan here, we would have completely missed the lesion that the methionine imaging is clearly showing. And you can see the background uptake. There is background uptake in the brain, but not as bright as what we see in FDG imaging. So the way we're performing methionine, as I said, it is not FDA approved, and yet we're a community hospital doing this. But we do have a special expanded access program where a special permission is granted by the FDA. It turns out we're one of the two sites that are really given this special expanded access, and certainly one of the only adult sites in the US to be able to do this. The other site is St. Jude's Children's Hospital. Again, they use it in pediatric patients. It's not to say that other sites are not using it. They have special INDs, research INDs that they can do it for specific studies, but we're kind of doing it as a very routine standard clinical care in our patients, at least under this particular program. So how do we do it? Patient usually fast. Now we usually do methionine and FDG in tandem together, so the patient is fasting anyways. We inject about 20 millicuries or 740 megabecquerels. Uptake time is about 20 minutes. And then again, you want to minimize patient stimulation after the injection. And then once that's done, we immediately follow it up with FDG injection for brain imaging, since the patient has already been prepped for that. Again, same thing, same concept, where we show you that there's uptake in the methionine, but not FDG. And I believe this was the same patient where at a different location in the brain, the patient has another lesion, which actually does have methionine and FDG uptake. So this is important now, because as you can imagine, automatically you start thinking that there may be something different about these lesions, and indeed that is what the future is going to hold in terms of being able to decide what kind of therapies to give and how aggressive we should be with these lesions with the various modalities we have to treat these patients. Again, just a quick cartoon to show you, as you know, how FDG works. C11 methionine works by the same overall sort of analogous mechanism by going through transmethylation. But as I showed you, the transporters are the LAT2 and ASCT1, which take up amino acids across the cell. So this is a case of where there is a very low-grade tumor, and both methionine and FDG do not have uptake. So what we know that this could be a benign lesion, and unfortunately, it could also be a very low-grade tumor. So yes, there are some lesions that even methionine may not pick up that could be malignant. But what's very encouraging here is that this lesion is probably not going to move very well, and the overall prognosis is quite good. And this lesion can be fairly well extracted if it need be surgically, without worrying about too much about where the margins have to be exactly. So as I mentioned, C11 methionine does pick up the lower grade lesions. There is some blood-brain barrier dependence. For example, methionine uptake does not rely on the blood-brain barrier to be breached from the tumors. There is going to be some uptake, but there is transport across the blood-brain barrier, so that does become a rate-limiting step. The higher grade lesions will have increasing uptake. So as I mentioned, as I showed to you, that could be of great interest to us in terms of figuring out whether we're dealing with a more aggressive lesion or not. And not only that, we know that deactivation of amino acid transport may be an early indication of therapy response. So often we can use it serially. Our own experience at Kettering Network has been that using all three MR with PET, FDG PET, and methionine PET provides the most useful information clinically in order to make the decisions we need to do. So there is added benefit for PET in staging, particularly at the time of recurrence. This is a case of an infiltrating glioma. If you look on the slides on the left side, you will see on the top FDG images in the temporal lobe. In the left temporal lobe, there's sort of lower grade FDG uptake and a little bit higher grade methionine uptake in that same area. So this was a patient who had diffuse astrocytoma, a lower grade tumor, and the recurrence was a glioma which progressed to a glioblastoma. And so we're seeing that demonstrated over here. Now, there's more advantages to this. For example, we see a lesion, which again, the question was, is this recurrent or not? This is the MR findings, and then we have the CT findings, not much on the CT. And of interest was that when we did the PET imaging, which is the FDG PET at the top and MR at the bottom, notice on the FDG image, you'll see there's a very slight decrease uptake on the in the right hemisphere compared to the left. That's because the patient's been treated with radiation in the past. But we look at the methionine image, that doesn't exist. And so particularly the area of lesion, both the FDG and methionine images are negative. But you will notice that on the left side, there's a focal hotspot. And if you go back to the MR image and we fuse that, we actually see that there is a little tiny nodule that's sitting there. It's there on the MR, but was missed on the initial read. And the MR and the methionine was able to help us light that up and find it. So again, PET is adding to things that, even though it's there on the MR, it could be very difficult to pick out and really assist in the patient's management. So what are the implications? So more, again, as you all know, we're in the era of molecular imaging. So we're really beginning to look at all these modalities as biomarkers. It's not just that we like to diagnose something, but they're using it as a biomarker along with genetics and all the other clinical information of what the tumor is potentially doing. So again, we could assess the aggressiveness of malignancy beyond just what the surgical pathology tends to show. And then we can use this to guide treatment paradigms such as, do we do surgical resection, or how do we do it? Radiation usage, how do we use the radiation? How do we sequence these therapies? And can we relate this uptake to the actual genetic profiles of the tumor, non-invasively? So I'm going to just run through some other tumor types that can show up. For example, this is a case of an astrocytoma, grade 2. There's FDG, not much uptake in the tumor. which you can see the right mesotemporal lobe. Methionine uptake also just kind of has a very mild low-grade uptake in this grade 2 tumor. But now as we get to sort of a higher grade tumor, you can see that there's more methionine uptake in a similar area, whereas the FDG uptake, there's also starting to be FDG uptake here, again, showing you that you can have a more aggressive tumor that will light up metabolically much more. This is a case of a metastatic adenocarcinoma of the lung, where we see FDG uptake at the top and methionine. Notice again, the uptake is not as robust on the methionine imaging. So one of the points and going to yet another tumor type, here's a patient who started developing changes in the MRI, and we can see that on FDG, these changes are developing slowly. And when the methionine imaging was done, a little bit more prominent than the FDG, but again, not super hot on the methionine, which kind of shows to us that we have to kind of judge how we look at these scans based on what kind of pathology we may potentially be looking at. So it's not easily just, you get high uptake across the tumor lines, but you kind of have to look at what tumor line you're looking at and what that implies for its aggressiveness and grade of the tumor that we may be seeing. So one of the important roles of PET, and I'm hoping my colleagues will be able to do a much deeper dive into this, is therapy planning. For example, it's a well-known fact that the lesion margins on MRI are often exceeded by the metabolic margins with tracers such as C11 methionine PET. Again, what are the surgical and radiation oncology implications? My colleague, Dr. Satter, will be talking about. There's often the problem of radiation necrosis versus recurrence, which again will be discussed a little bit later. Again, that is problematic with MRI, and I won't say it's perfect with PET, but it certainly improves the differentiation between the two when added with the MRI data. But again, like I mentioned, the diagnostic criteria may be different based on what kind of tumor that we're looking at. Just to kind of show you a slide of how therapy planning is done. And you can see that the methionine uptake here kind of seems to extend beyond what the MRI margins may tend to show. And we certainly are using the methionine data to enhance what's seen on the MRI. I would say most everybody else that's not doing PET does not do that. So we are certainly integrating PET into our treatment areas. Again, this is a patient with a renal cell carcinoma. The question is, this patient's gone through surgery and external edema. Is this a recurrence or not? We're getting similar uptake on the methionine and FDG type images. This would tend to sort of lean towards more of an inflammatory response than a true recurrence based on the pattern of disease we're seeing. And again, the pattern is going to be very important in nuclear medicine. I'm not going to get into much about using SUV ratios and other things like that and other quantitative parameters that are useful, but suffice it to say we don't tend to use that as much because we feel that it doesn't really add a lot of information in these cases. This is a case where a patient was suspected to have a recurrence for an adenocarcinoma of the lung. So they did an early FDG PET scan down, you can see at the top in the posterior right parietal and sort of occipital region. And then that was the early post-op staging FDG, then a suspected recurrence. You can see there's a little bit of FDG uptake in that area. And then the suspected recurrence with methionine also showed some irregular uptake at the margins. When the biopsy was done, this actually turned out to be negative for a recurrence, and I believe the scans are also read as being negative for recurrence. On the other hand, if you were to look at something like this, where we have FDG uptake and methionine uptake, there's quite robust uptake in both there. And one might think that this is recurrence, but actually this did turn out to be necrotizing granuloma and consistent with chronic inflammation. So this is a case where it is false positive. So yes, we do get them, Again, it just improves what we see MR. Here's a case where on the left side, patient had methionine FDG imaging done once upon a time, and the patient came back with seizures and having frequent seizures. There's a question of whether they had radiation necrosis or recurrence of tumors that were triggering these seizures. And when we did the methionine and FDG, remember we do the methionine scan, then we do the FDG right afterwards. There's this sort of diffuse uptake that we see on the methionine scan and not much there on the FDG scan. And this is due to seizure activity. Now the question is, did the patient have a short seizure right before the methionine injection, or was it that they're just having frequent seizures and that part of the brain was just active and took up methionine anyways, even though that they may not have had an active episode at the time of injection. But nevertheless, it is pattern recognition, and this is not all tumor. This is indeed seizure. And there are case reports out there, but it's interesting. Being a community hospital, we do this all very advanced kind of imaging, but we don't have the manpower to publish our results, which is a shame because I think the world needs to know it. These are published as case reports where we see these quite frequently in many of the things that we do. Here's a case where we have glioblastoma, where a positive methionine scan, negative on the FDG scan. But when they biopsy, it turned out to be a high-grade glioblastoma, which is surprising because, like I mentioned, that those are the lesions we tend to see positivity in both the FDG and methionine. So it's interesting. Like I said, we're really looking at biomarker imaging. So even though the pathology shows a certain type of high-grade tumor, the PET is kind of adding to all the profile we already know about the disease and adding a layer that this may actually be a less aggressive variant of a high-grade tumor. And again, what the treatment implications for that would be very interesting to be able to study. But there are future tracers coming up because C11 methionine having such a short half-life is dependent upon a cyclotron being in the vicinity. There's a development of fluorine-18-based tracers, such as FET, which is fluoroethyltyrosine. But there are some of the older ones like F-DOPA. I've mentioned C11 methionine here. One of my colleagues will talk about their research at the University of Pennsylvania in Philadelphia with regards to flucyclovine. Dr. Satter will very briefly touch about PSMA agents. But again, these are all sort of not specific. There are now very specific agents being developed specifically for glioblastomas. And then there's some other also non-specific agents such as somatostatin analogs. And I will be showing you just a couple of quick examples of those. The F-DOPA mechanism, for example, it is a catecholamine analog. It's taken up by neuroendocrine metabolism, concentrated into neurosecretory granules. And it is very useful in the use of, again, low-grade brain tumors. The radiochemistry is rather difficult for F-DOPA. Otherwise, it is F18 based, so not so much in a rush to image that as compared to C11 methionine. Here you can see a low-grade lesion lights up of the F-DOPA PET scan where it did not on the FDG. And there are several papers showing that to be the case, where F-DOPA is going to be a lot more useful to use than, say, FDG imaging in figuring out and identifying these low-grade tumors. This is a case where this is a lot of slides here, so it's a little confusing, but at the bottom is an MRI where methionine and FDG PET were done. If you look at the right periventricular space laterally, there is a small area where there was thought to be potential early recurrence. And when they did the methionine and FDG imaging, there was not much uptake in those areas. But over time, on the top, that tumor was that area seemed to progress and grow. So again, on the left side at the top, we see going from right to left that the tumor became larger and this area became larger and larger on the MRI. And we did, because this was an anaplastic meningioma, we tried correlating with a DOTA-Tate PET scan, and you can see that actually has uptake in that area. which turned out to be tumor recurrence and tumor progression. So again, another tracer that is familiar to most of you. In this case, it's gallium, excuse me, gallium-68. We are using the copper version at this point. But again, if we know what tumor we're dealing with, it can pick out the right agent to use to image. This is from the literature in regards to using FET PET. This is a patient who had a baseline imaging and a retest. They did it just to look at the variability of uptake. And you can see that there's a fairly robust uptake of FET. But interestingly enough, after chemotherapy and radiotherapy, there's a lot of uptake. And this scan was done only 1 week after chemotherapy, radiotherapy was done. And so again, timing of that imaging is very important because the therapy has been completed and yet we see a lot of uptake in the tumor. So it's important to let the inflammatory component sort of die down before we go back to re-image. So in summary, PET imaging does provide incremental advantage over MRI imaging. It assists with initial staging, provides some biomarker and metabolic information, and can be useful in monitoring treatment and recurrence. And future tracers hopefully will improve imaging performance and provide incremental prognostic information and will be disease specific. I have not even touched upon the diagnostic implications with regards to all these, what I've showed you, because I think there's a lot to cover just from the imaging standpoint and the program that we have set up. And I thank you for your attention, and I will now turn this over to my colleague, Dr. Peter Bouz, who is one of our neurosurgeons, who very much are dependent upon a lot of the C11 methionine images that we use, and I will let him give a short talk on how that influences his clinical management and decision making. And I would like to turn the session over to Dr. Bouz now. So Dr. Bouz, as I mentioned, is my colleague here in our neurosurgery program, and one of our physician champions. I will say that, again, being a community hospital, several years ago, our cyclotron was up for renewal, and there's a big question whether or not in a community hospital setting they really needed a cyclotron. And I must say it was really the push by our entire neuro oncology program to say that, yeah, they really did want that. It was very useful for them.
My name is Peter Bouz. I'm a neurosurgeon here at Kettering Hospital with Dr. Arif, and predominantly involved with the cranial procedures, tumors, and vascular. Wanted to kind of collaborate a little bit on the talk from Dr. Arif. It is very important for us to kind of push the advancement of the PET imaging. We heavily rely on them during the surgical decision making, and would like to see that field of medicine to get a little bit deeper and broader in the assistance of diagnosis, and especially in the age of where the resection is very much tailored to the pathology here. So I do rely heavily on PET imaging, and I'll share a few examples. Some of the surgery are mine, some of them are borrowed from the utility of the PET imaging. So this is a case from last week of mine, where this is a 62-year-old gentleman who presented with seizure. And as you can see there, the ring enhancing portion is a contrast enhanced image on the left side of the screen, with the ring enhancement portion measures approximately 17 millimeters, so relatively small lesion. With bottom slide shows some of the flare imaging, bit of a flare signal around the lesion that extends somewhat beyond the margin of the tumor itself, which we would anticipate. However, on the PET with methionine image there, and the right corner of the screen, you see that the borders of the tumor is significantly larger than what we see on the contrast enhanced imaging. The way that I approach this type of a pathology, first I plan my craniotomy to extend beyond the margins of the contrast enhancement, as I anticipate resection that will incorporate the methionine or the PET imaging margins. I do suspect that this would be a high-grade glial neoplasm based on the PET imaging. Therefore, I plan my craniotomy accordingly. We start with the biopsy, or a small sample is being taken from the contrast enhanced segment, which I confirm then that this is indeed a neoplasm, and a glial neoplasm. And then I proceed with the resection of this lesion, incorporating the margins that we would fuse then with our navigational system to resect all the portion of the PET imaging as indicated there, where the high-grade neoplasm is suspected. So this is kind of how apparently small lesion on the contrast enhanced MRI, if that was used as your guide in the resection of the tumor, would significantly underestimate the extent of the tumor, leading to significant residual and quick recurrence. So some people would use the flare signal as their guide in the resection, and I've used that too before we had the utilization of the PET images to the extent that we do right now. But even with the flare, the signal can be pretty extensive. Sometimes you in the brain, especially in this case, you encroach in a premotor cortex, so you don't want to rely on a flare signal because that does not correlate with aggression. However, resecting the flare signal would be very much desirable, but not always possible given the location of the lesion. So that's how this pathology did turn out to be a high-grade glioma, and significantly wider margins were taken compared to what the contrast enhanced MRI showed. So that's kind of a utility of that. So extent of the lesion beyond the sort of traditional approach utilizing the contrast enhanced imaging is kind of how I utilize the PET imaging. We talked about some of the border slides. These are the decision making in radiation necrosis versus recurrent lesions. We are often faced with an almost entire population of high glial neoplasm patients will come in with some sort of abnormality on the surveillance scans. We image them at 3 months interval, and we do often see abnormalities in the tumor cavity. Obviously, the cavity itself will have some scar formation as apparent on the surveillance imaging. However, the decision lies in kind of determining, is this just a postoperative scarring? Is this a radiation necrosis, as we utilize significant amount of radiation in these patients? Or is this truly a recurrent type lesion? And this is kind of where the decision making surgical decision making is important. We just watch the lesion that is radiation necrosis, or do we go back for resection? And if you do resect, what exactly we are resecting? Are we resecting the scar tissue, or are we truly incorporating the area where the true recurrence is seen? And so oftentimes we have, and as a matter of fact, in entire population of some of these glial tumors, you will have the combination of postoperative scarring, radiation necrosis, and true recurrence. So to be very precise in the surgical approach, one would have to make sure that we incorporate, most importantly, the metabolically active portion of the tumor. And so that's where the PET imaging is vital in making sure that that we're not compromising the well-being of the patient, and truly resecting stuff that is needed. That also will influence the postoperative recovery and prognostic values to the patient. So these are the kind of images that illustrate that. another example of a decision making in regards to, is this a low-grade glioma, or is this a truly a tumor that has a higher grade within it. And some of these slides really illustrate the validity of methionine, and in determining whether this is a low-grade glioma or not. All these cases are often called by radiologists as a low-grade glioma, since there's no contrast enhancement on the T1 imaging there with contrast. So traditionally they were thought of as low-grade glioma. We're utilizing the PET imaging. We're starting to see that there is a higher activity that leads to a different pathologic diagnosis during the surgery. So I was also asked to talk a little bit about the LIT therapy and how that influences, and how does the imaging that we get utilizing the PET scans contribute to the surgical intervention. So there are several surgical advancements that are currently being sort of used and advanced through our in our specialty. LIT is the laser-induced interstitial thermal therapy. The notion that a little brain damage is okay is actually something that I think was behind the development of this technology. Especially when we're dealing with the recurrent tumor, some going through previously radiated skin, going through the scar, or even treating a tumor in a very eloquent territory. We don't have the luxury of utilizing the aggressive surgical approach here with these patients. Therefore, the minimally invasive type of approach is being often used, and LIT is a very advanced technology that's being utilized at our institution heavily, one of the larger volume of treated brain tumors using LIT in the United States. So how is this differ from our routine standard type of surgeries? Is the LIT consists of several steps. So patient is taken to the operating room first, where we place the frame. We utilizing the navigation system. The navigation system again uses traditional contrast enhanced imaging, often fused with the PET imaging, and that kind of gives us a trajectory of entrance, point of entrance, and target. We select those. We place a access port, if you will, in the cranial area of interest, and then patient is taken to the MRI. It's a complex setup. However, we have a well-oiled flow with these type of technology, where in the MRI, through a variety of probes, the heat is being delivered to the area of interest. The heat, basically, if you will, we essentially cook the tumor. If that's kind of how I would describe it to those who are encountering, or to the patient even. So if we got the tumor, we can either go in and resect it. Oftentimes that is not possible. We can get back through a little probe with very little damage to the brain tissue as we get into it, and essentially cook it at the type of a temperature that will fry the cells, destroying them and destroying the blood supply to the tumor, leading to the cell death. And as you see, there's the image down below. What I have is the temperature settings that we can adjust. We can control this via the robotically controlled probe. Variety of probes, variety of territory can be incorporated. We do our planning based on the anatomy, based on location, size, etc. So there are we have multiple probe types that can be utilized depending on the shape. And in the MRI, where we confirm adequate placement and the zones that need to be treated, we deliver the thermal energy to basically fry the tumor. Again, that's where some of these images here also borrowed, that you can see on the left upper, high-grade glial neoplasm incorporating eloquent, non-resectable territory. This is something that is traditionally would be told to a patient that this is non-resectable tumor. You would not go into the deep basal ganglia thalamus type of territory. However, the lit therapy has been proven to be very useful. Some other images there, kind of, where some metastatic lesions can be they can be treated. We can also use the same probe that we would deliver the thermal energy. We can use that as a biopsy. So often we would biopsy through the same probe and then induce the energy to treat some of these tumors, showing a pretty good resolution with time. And that's all for my presentation.
We're doing very exciting stuff with not only PET imaging, but novel surgical techniques, which are also being used very rarely and mostly at academic centers, let alone community hospitals, and being able to marry something very advanced, such as amino acid imaging, with these techniques, such as LIT, is very exciting for us to be able to offer our patients. I think we truly are a hidden gem with terms of neuro oncology and our abilities to work with this. Our next speaker is Dr. Martin Satter. He is our medical physicist with the official designation of Chief Molecular Imaging Scientist. And he's been basically around Kettering almost since the inception of the PET program, and certainly with methionine imaging. So he assists a lot with regards to radiation oncology and our neurosurgical colleagues in terms of their treatment planning. So I will hand the session off to him so that and he can talk about some of the stuff that they've done, some of the things that we're thinking about doing. And I think a lot of what he says, he's passionate about nuclear medicine. A lot of it is preaching to the choir, but hopefully he can kind of show you some of the innovative ways we have integrated PET into treatment paradigms for neuro-oncology patients. So, Dr. Satter, I'd invite you to help take over.
All right, thank you very much. Good morning, afternoon, or evening, depending on where you are. My title of my talk is PET molecular imaging, kind of in the era of precision neurosurgery, a new paradigm. In terms of disclosures, no disclosures, but I would like to point out sort of the miracle of PET molecular imaging at Kettering can really be attributed to one person in particular who retired about 4 or 5 years ago, Dr. Joseph Mantle, who is our director and fiercely fought for getting us a lot of the technologies, in particular PET technologies at Kettering. So I'd just like to acknowledge him in this talk. So just as a preamble, I'm a PET physicist, and as Arif has mentioned, I've been here a long time. In nearly all that time, I've been working very closely with neurosurgeons. This talk, done at behest of Dr. Sheikh, is more of an observation at 40,000 feet. It is not a clinical talk. I'm not a clinician, but more of an observation and an optimistic prediction. In short, my talk might be better entitled PET Molecular Imaging. We put the accuracy back in precision neurosurgery, and in all likelihood be more valuable if I gave it to neurosurgeons. Finally, these observations I have may already be common knowledge over there where you are. I'm aware that actually PET molecular imaging in many other countries has actually forged ahead where it stands here in the United States over the last decade or so. So how do I define precision neurosurgery? Well, a picture's worth 1,000 words. This is from an NVIDIA conference on using artificial intelligence and machine language for medical imaging. And what you see is this incredible data set. This is actually data from a patient. And you look at this in awe because it's literally, almost virtually, a human being that they've recreated. And you ask yourself, how do you do this kind of thing? The answer is you get information from many different sources and you very carefully patch it together using technology called image co-registration. In this particular case, you're looking at the combination of MR and CT, magnetic resonance angiography, computerized tomography angiography, diffusion-weighted imaging, diffusion tensor imaging, so on and so forth. So we've been doing this for a very, very long time at Kettering. This is an image from a little over a dozen years ago, where same kind of thing. Here's an MR image on the left, showing a motor strip activation, and then on the right, the diffusion fiber tract imaging. And of course, when you put that virtual patient together on the computer, the next thing, of course, that makes it of value is you have to match it to the patient as they're laying affixed on the surgical bed. And so basically the patient is co-registered to their virtual brain as it exists in the computer. And this link is usually performed through some kind of spatial tracking technology. Now, this weird looking thing that you see here is actually, again, a slide from many, many years ago, because we got the original viewing wand, as it was called, circa 1996 or 97. And you can see there, this is basically a mechanical six-jointed arm that you can monitor the position of the tip of that probe in real time. And that obviously then provides the link between the patient and their data set. So we used this technology back in 1995, and we're one of the first or second organizations in the country to incorporate PET molecular imaging into this technology. And you can see kind of the value of this. In this case, this is actual footage from one of our early surgeries, and you see one of the neurosurgeons is positioning the probe. You can then take a look and see, in this particular instance, the probe, the tip of the probe is projecting down through, I think that's a draining sinus or a vein of some kind, on its way to get to the green tumor that you see there. And obviously when he adjusts his hands a little bit, now you can actually get out and under, you can get to the tumor without intersecting any of the vasculature. So this is the power of this kind of imaging, and certainly back in 1995, the expectation was this is going to make a tremendous difference. I mean, if you imagine up to that point, what neurosurgeons had to do, they literally looked at a two-dimensional film, they walked over to a three-dimensional head, and they made a hole trying to estimate exactly where the tumor was underneath all of that. So it's amazing they did that in the past, and certainly the idea that you could quantify that and improve the precision of that made everyone very, very excited about this technology. But eventually, the mechanical arm that I pointed out was replaced with different types of tracking, providing even more accuracy and precision. The stage was set again for what we believed would be a remarkable improvement in the treatment of brain tumor patients. And there was an improvement via reduction in surgical complications, you know, as image-guided surgery technology allowed surgeons to then open up much smaller holes, much smaller craniotomies, as well as avoid, you know, brain's most critical structures, as I kind of demonstrated earlier. However, what was not seen was a significant improvement in the treatment, in the eradication of the brain tumors themselves, in actually extending patient lifetimes. And this was attributed early on to something called brain shift, for example, and brain shift is kind of the loss of calibration of the patient to their virtual brain during the course of the surgery due to actual patient brain motion. So for example, when I've been at and witnessed certain neurosurgeries when they open up the craniotomy and literally the brain can ooze out or suck back in based on differences in pressure during the case. And obviously when that happens, all your carefully pre-planned image guidance goes out the window. And of course, that then stops your ability to maximize a gross tumor resection and improve the probability for your patient to do well. So for example, we attempted to fix this with intraoperative imaging back in 2005 via this battery-powered portable CT originally designed to be used by the military. And the bottom line was what we found is even though potentially, certainly we could try to detect bleeds and percent resection and Could improve biopsy, spine surgeries, obviously, and correct brain shift is a big one. In reality, at least back then, although coined interoperative, it was still crippled by a lot of logistical obstacles and poor resolution. So we didn't really see much of an impact. There's other things we did where if you're combining all this information and you have a neurosurgeon that has to keep looking around, what about projecting that information directly to the patient or to the neurosurgeon's vision? This is a microvision goggles. These are laser goggles that literally raster a laser image to the back of the retina of the neurosurgeon. They're see-through, so you can put all kinds of information up and into these goggles and put them into and allow, for example, overlay. So you could, for example, see the diffusion tracks in overlay on actual brain tumor during the course of the neurosurgery. And everything just kept progressing. You can look here, just taken from online. This is a stealth integration web page. So you've got all this capability now to track the location of your instruments via electromagnetic navigation. You can attach robots to your image-guided system, microscope integration, obviously, O-arm, which is kind of a poor man's CT, or full-blown CT, much better CTs now, ultrasound integration, MR scans. In fact, if you want some very serious precision neurosurgery and you have a lot of money, you basically can purchase basically an MR on wheels, where basically you have an MR on one side of a wall where you use it typically for your radiology imaging. But on the other side of the wall, when a neurosurgeon needs it, you can push a button, doors open up, and the MR comes marching into the neurosurgical OR to be used to address those issues where you might have brain shift correction, those kinds of issues. And again, very serious precision neurosurgery can include something like proton therapy, where again, the idea here is even more precise deposition of your dose so that you can extract and have better tumor killing and obviously spare normal brain tissue. So with this kind of onslaught of technology, actually I got one more slide, I'll go forward. There's one other piece actually Dr. Bouz had mentioned. This is the NeuroBlade system where you're allowed to go in and in real-time MR guidance basically melt a brain tumor with real-time thermometry. So I'll just go back here and then say with this onslaught of technology that we've had over the last 25 years, it sort of begs the basic question, how are we doing? And you can look on the literature, for example, this is a publication out of Japan from April this year looking at proton beam therapy for gliomas, multi-center prospective registry study, with the disappointment that for glioblastomas in particular, that the outcomes of proton beam therapy are pretty much equivalent to what we've always done, using basically old school radiation therapy. Or you can look at intraoperative MRI, and again, a recent publication looking at a multi-center trial, trying to compare intraoperative MR, the MR on wheels, and see what its impact might be. This is a case that I think altogether had over 700 patients. And again, additional supporting evidence is still needed to determine the clinical value, basically, of intraoperative MRI, especially in the management of glioblastomas. And unfortunately, even in the case of LIT, neuroablation, we're seeing in multiple papers that you're really not seeing much of a difference in terms of patient longevity, in particular for things like GBM. There's a couple cases here. So with all this precision, how are we doing, in particular looking at glioblastoma? And again, I guess having been doing this for a long time, I'll be a little bit arrogant to go ahead and grade these technologies, and pretty much these very expensive ones I'll get a C because they haven't really moved the needle very much. and they're all extremely expensive. We'll give NeuroBlade a break because it's not nearly as expensive and does offer a lot of opportunity for addressing treatment of tumors that you don't have with traditional image-guided surgery systems. So we've got to come back to this original picture and say, what are we doing here? What are we missing? So if you look carefully, this is actually a brain tumor case. If you look at that red arrow, that's pointing to an MR image of a brain tumor. And so you sort of have to go back to the very basic question of what you're doing and wonder if perhaps you're not like the gentleman that's looking for his keys under the streetlight because that's where the light is, even though the keys aren't there. So it seems logical that to destroy biochemical processes, you need biochemical information about those processes rather than biophysical information. And here's a case, this is our third case where after we developed our own image co-registration, this is an FDG and an MR scan. The MR had contrast, and you can see clear evidence of a GBM, grade 4 GBM on the PET scan, and not so much on the MR scan. So the PET detection of a tumor, one not really easily seen or not seen at all on a high resolution MR image is a rare occurrence, but you have to understand the reason for the rarity isn't because it doesn't happen nearly all the time, or perhaps nearly all the time, but because PET is still so barely used relative to MR in clinical practice. So one of the things I do to try to get everyone to think about this a little bit, I have a simple kind of thought experiment about what MR and PET are really all about, kind of at the molecular level. And so if you were like me and old enough to remember, there was a movie back in 1968, excuse me, where they shrunk everybody down into a little submarine and injected it in the human body. And I'll show you in this thought experiment again, then if you do this, how you can create an MR, CT, and PET scan if you jump in this little submarine. If you do that, you jump in the little submarine and you're trying to do a CT scan, all you have to do is go to all the little places in the body you want to measure and get a voxel on your CT scan. Take out a scoop of a uniform size, scoop up a piece of tissue, and go and weigh it. Just put it on a scale and weigh it. Keep track of that information of where you're at. And literally, you could create a CT scan of a patient. Again, a thought experiment. But just based on the idea that what CT measures is really density, electron density. And of course, in the case of an MR scan, a little more sophisticated, but not that much more sophisticated. Here you could jump out, and of course, the patient's in an MR scanner, so there is a uniform magnetic field pointing in a given direction. You could just take out your Boy Scout magnetic compass and pull the needle off where it was aligned to the MR image or the MR field, and then time the amount of time it takes it to snap back to where the MR is pointing, where your uniform magnetic field is in the MR scanner. And based on that time, you could literally, per voxel, report that information and create an MR image. So biophysics measurements have really little relationship to biochemistry, and cancer is really a biochemical process. And this is especially exacerbated or can be thought of when you realize that most of the time you don't even get that typical brain tumors, as they exist normally, don't have tremendous differences in what they weigh or in their magnetic properties. So obviously we enhance them using contrast, but that contrast in that brain tumor then only appears after the tumor grows to an extent that it creates its own leaky vasculature, allowing the contrast to leak in, and then you can see the tumor in the first place. So what we've done here, I think, over the last 25 years is focus on precision, but not accuracy. So precision up in the upper left, it looks really good. We have a nice bunching, we have a nice reproducibility, but unfortunately we're missing the target. In the case of the ideal situation here. Obviously, we want high accuracy and precision. So we've kind of gone gangbusters on the precision side of things, but forgotten that we're really not hitting the target. So PET molecular imaging provides new and better information because it really enables biochemical assays to be performed in vivo. And here you see an example. I think you've seen this before. This particular case of a methionine scan, the brain tumor volume via the methionine scan is 5 times larger than what you can get out of the MR contrast. So in this particular case, if you were to treat the MR to the MR image, you're only treating about 20% of the brain tumor. So PET molecular imaging is imaging biochemistry, and it's as simple as when you jump into your little submarine and you have a Geiger counter, you're simply going to measure the positron density. And that's all that the PET scanner does. But a PET image is a mapped positron density, and in contrast to MRCT, the positron density is dictated by biochemistry and not the properties of the tissue or the contrast material. So we need tools for accurate personalized medicine, and the result is that I think the future is dictating that to combat diseases which are biochemical in nature, we need tools whose mechanism of action are biochemical in nature. So biochemistry obviously hasn't changed much in the last 25 or 30 years. But what has drastically changed over the last decade especially is the information we have learned about biochemistry in both healthy and disease processes. And this exponential growth in understanding is really attributable to the Human Genome Project, initiated in 1990 and completed about a decade later. So when you look to the future and you look at these PET brain tumor agents, you have some traditional ones such as FDG and methionine and fluoroethyltyrosine, but newer ones that are even more specific going forward. And understand that it currently, if you go out on the web, you can search for the number of PET radiopharmaceutical vendors, and I found at least 55 of them. And if you add up their pipelines, they have over 140 different PET molecular imaging agents that they're working on. Some of those will, of course, be even more specific to brain tumors and other types of cancer that exist in the body. So what we do, for example, with brain tumors now, as mentioned a little bit by Dr. Bouz, we get a methionine scan, we get a PET scan, we co-register that data, and then to work up the patient, a mirror image of the PET brain tumor as segmented by the user is mapped to the contralateral side of the brain. The methionine activity is measured, and the brain tumor is further delineated by segmenting regions only above a certain tumor to contralateral tissue ratio, typically in the range of 1.5 to 2. The PET lesion is then marked as an RT structure, put in a DICOM data set, and sent on to the MR-guided neuroblade system. Currently, we use the Monteris system. And again, as Dr. Sheikh mentioned, excuse me, we can perform these procedures due to an expanded access IND for PET methionine granted from the FDA. And we typically average about 60 to 80 of these kinds of studies a year. So the last thing I want everyone to consider is a timing issue. So for nearly all the PET scans ever done for brain tumor, and probably nearly all the PET scans ever done for any type of cancer, they almost always come with a precedent anatomical scan. So the real question you want to ask yourself isn't just location, 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 but one of timing. And so I've yet to see sophisticated studies, long-term and big-time studies, where the PET scan dictated when the biopsy was done. In almost all of these cases and all the literature, you have some MR trigger that triggers the PET scan being done. But of course, again, if you think about it from a biochemical standpoint, it stands to reason that the PET signal is going to show up first. And especially in something like a brain tumor, that's going to have an even greater impact. So more than just the augmented value or whatever that currently you see with an MR scan, where you have an MR tumor and you see a slight difference, I think the future is going to be one where you're going to actually use PET imaging first, and it's going to trigger the treatment and the biopsy. And of course, a lot of this is going to be pushed by genetic testing, your early cancer detection via blood sampling. If you think about it, what are you going to do when you have a blood sample, you do your genetic profiling on it, and it indicates a lung cancer or a brain cancer, and then you go do an MR or CT scan and you can't see it? It's going to push PET molecular imaging into the fore, because your earliest chance of seeing it is going to be from a biochemical standpoint. So in conclusion, PET molecular imaging is an entry point to accurate medicine, and it should greatly improve brain tumor treatment as it grows exponentially in the clinical arena. Thank you very much.
All right, thank you very much, Dr. Satter, for that presentation. It is my great pleasure to introduce our last speaker, Dr. Ali Nabavizadeh, who is, I've heard him talk over the web. He's at the University of Pennsylvania. He's an assistant professor of radiology at the Hospital University of Pennsylvania, with a research appointment at the Children's Hospital in Philadelphia. He's also the director of the Translational Imaging Unit at the Center of Data-Driven Discovery at the Children's Hospital, and the imaging lead of two consortia. These consortia are respectively dedicated to the biospecimen-driven data generation and precision medicine clinical trials. Dr. Nabavizadeh has been his research has focused on multimodality imaging using structural and physiologic MR imaging with additional PET probes and molecular imaging techniques to better understand the complex nature of brain tumor microenvironment. He has more than 100 peer-reviewed publications in prestigious journals such as Nature Communications, JAMA Neurology, Clinical Cancer Research, Neuro Oncology, Radiology, JNM, and has served the principal investigator of multiple prospective imaging trials, including investigator-initiated trials and industry-sponsored FDA registry trials. I have been very fortunate to be able to get hold of him to present for us. And without further ado, I give to you, Dr. Nabavizadeh.
Thank you very much, Dr. Sheikh. Thank you very much, everyone, for attending. And also, I want to thank the organizers and Dr. Sheikh for inviting me. I'm going to focus on fluciclovine PET imaging, and through that, I'm going to also mention some of the relevant literature. And these are my disclosures. And I'm going to focus on the different amino acid transporters that Dr. Sheikh also mentioned. I'm not going to talk about FDG because already quite some slides have been shown in previous talks, and comparison of fluciclovine to different amino acid PET tracers, and some of the available literature in glioma and brain metastasis, and some of the ongoing efforts. So when we talk about PET imaging in glioma, in the past couple of years or so, there has been a significant interest in the field, and people have come together and published guidelines. This is one of the initial papers that came from ENM, EANO, and RANO kind of groups that put together the practice guidelines for imaging of glioma using FDG and other amino acid tracers. And what they concluded was that the added clinical value of PET imaging, with superiority of PET imaging with amino acid compared to FDG, with the limitations that we are aware, and this guideline actually provided a framework for use of PET to assist in the management of patients with gliomas. So when we do amino acid imaging in glioma, we are dependent on two transporters, PLAT1 and ASCT2, and amino acids play a key role in many cancers, including glioma, and they contribute to cancer cell growth, signaling, and tumor growth. And so amino acid PET tracers. They come in different flavors. Analog has a 20-minute half-life, which limits it to centers that have an on-site cyclotron. Then we have 18F FET, which is a tyrosine analog. It's widely used in Europe and some of the centers in US. Fluciclovine is an L-leucine analog. It's a synthetic amino acid, and F-dopa is a phenylalanine analog. That is also FDA approved for Parkinson's disease, and it's being used in some academic centers. So this is an animal study using multiple, basically, GBM cell lines in rat GBM models, as you can see here. And why I'm showing this slide is that the beauty of amino acid imaging is that you're not dependent on contrast enhancement. Like you can see on these two animal models, the tumor is enhancing, and you see a lot of uptake on PET imaging with fluciclovine. And this is ASCT2, this is LAT1. But you don't have to have enhancement. Even in tumors that you don't have enhancement, you still see increased radiotracer uptake, which is great. So we're not dependent on a blood-brain barrier disruption. One thing about fluciclovine that makes it appealing is that it's FDA-approved for prostate cancer, which means that there is a wide network of commercial radiopharmacies that can manufacture fluciclovine, and then it means that it can be used in a broad scale across the US. So in terms of comparison of different amino acid PET tracers, this slide shows a comparison of FET and F-dopa. Sorry about that. You can see that there are no significant differences. You can see that this GBM kind of shows similarly in between these two patients. One of the limitations of F-dopa is that because there is uptake in basal ganglia, if the tumor is in that region, it can be hard to differentiate the tumor from the basal ganglia. But we can see comparison of FET and C11 methionine also has been done, and there has been shown to be a strong linear correlation between the SUV uptakes of both tracers, both at the normal brain and also at the level of the lesion. As you can see here, methionine and FET PET kind of show kind of similar uptake, and both tracers have been shown to differentiate tumor tissue from treatment-related changes. This is a study comparing fluciclovine with C11 methionine, and again, it showed that both tracers correlate very well. One difference is that there is significantly higher image contrast on fluciclovine PET compared to C11 methionine. In other words, the brain uptake is much lower on fluciclovine PET for normal brain compared to C11 methionine, which you can see that if the lesion has shown a high uptake, again, lesion can be seen on both. But if lesion is kind of borderline, only mildly elevated, you can see that basically it's easier to identify the lesion on fluciclovine PET because of much lower brain uptake. And so looking at the indication of what we use amino acid imaging for, we can use it from the time that the patient first presents with a mass, and we're not sure whether we're dealing with a neoplasm or a non-neoplastic entity like an inflammatory process or some weird infarct or other things. So we can use it for problem solving at that level. And during resection or biopsy, we can use it for assessment of the resection extent. We can use it for basically before doing the surgery. We can use it for planning the biopsy or resection. We can target the hottest area of the tumor, and subsequently we can after surgery we can use it to evaluate the extent of surgery, plan for radiotherapy, and also the imaging could be used as a baseline for monitoring the response assessment after chemoradiation. And similarly, after we treated the patient with radiation and chemotherapy, PET can be used to differentiate progression from pseudoprogression and to further monitor response assessment. This is a study that was published from Emory that used fluciclovine to differentiate between glioma in terms of grading, low grade and high grade. And they actually found that the cutoff value of 4.3 gives a high sensitivity and specificity to make that discrimination. And basically, this is what they published. And the ratio to the normal brain was considered to be less relevant compared to absolute SUV values. And the reason is that the uptake in normal brain is so low in fluciclovine imaging that it's hard to differentiate from noise. So the absolute SUV values are more important when we do fluciclovine PET imaging. So I'm going to skip some of the slides that are related to FET PET in the interest of time. But this is a nice slide showing that basically when a patient first come after surgery before starting chemoradiation with some residual tumor, this is a very common finding that we see increasing enhancement after completion of chemoradiation. But looking at PET imaging would be very helpful because even though the contrast enhancing size of the lesion increased, we can see that the radio tracer uptake significantly decreased visually. And if you measure it, indicating that this is not tumor progression, but this is a treatment effect. So I'm going to skip these FET slides and focus on fluciclovine and how we can differentiate progression from true progression. So discrimination of pseudoprogression and true progression is a real question every time we have a brain tumor board. So we have 5 patients every week that the neurosurgeons and oncologists are asking, is it true tumor progression or pseudoprogression? And it's very difficult on MR because what we see is that lesions that increase in size over months, and there is no way using conventional MR to differentiate between these two entities. And eventually, the lesions declare themselves, but it takes many months, which means like a lot of anxiety for patients and uncertainty and lost time in terms of recruiting patients into clinical trial that could potentially benefit patients. So, and it's not always that simple. Sometimes it's it's a combination of both. Like in this patient that you can see this lesion A, over time, the lesion A kind of decreases, as you can see, turn out to be pseudoprogression. However, this lesion start to develop after many months and eventually declares itself to be true tumor progression as evidenced by both conventional MR and perfusion MRI, which is helpful when we have access to it and when it's not degraded by artifact. The problem is that perfusion MR is frequently degraded by susceptibility artifact, like in this patient that you can see with this nodule. And that's why it's not helpful in every case. And that's why we need PET imaging, which is more powerful than perfusion MR. Like this case that the perfusion MR was non-diagnostic, you can see that the fluciclovine PET showed increased uptake, indicating that this is a tumor progression. And so in terms of diagnosing patients with pseudoprogression in glioblastoma, there has been significant literature using FET PET. But I'm going to skip these slides and focus on our study in fluciclovine. So this is a clinical trial that we performed at Penn a few years ago, actually during COVID, because we had a great collaborator where we were able to recruit 30 patients. And every patient had surgery, most of them within 1 week after they had a fluciclovine PET imaging. And so what we found was that the patients who had true progression and mixed progression means that patients who had true progression, they had 50% more tumor, and patients who had mixed progression, they had 10 to 50% tumor, and the rest was treatment effect. And the patients with pseudoprogression were patients who had 10% or less than 10% tumor. You can see there is significant increased uptake in patients with tumor progression compared to patients with pseudoprogression. And looking at the ROC curves, we can see that the SUV max, both at 20 to 30 minutes and 40 to 50 minutes, demonstrated high accuracy in distinguishing progression from pseudoprogression. And another interesting finding of our study was that when we combined the PET and perfusion MR, the accuracy even increased more, which is really good news in terms of how we can use the modalities and kind of in our advantage given their synergy. One example of a patient having kind of with true tumor progression, showing a progressive enhancing nodule in the tumor bed. Perfusion MR was non-diagnostic. You can see that there is some artifact, but also in the area that there is no artifact, there is no significant elevation. So this is a false negative perfusion MR. But PET showed a SUV max of 5.4 above our threshold, and this turned out to be 60% tumor. So this is an example of a patient with true tumor progression, mixed and pseudoprogression, and you can see the SUV max 6.7 in the progression, 4.7 in the mixed, and SUV max 2.6 in the patient with pseudoprogression. So important thing is that when we do fluocyclin PET imaging, there is always some uptake. So it's important to measure the SUV and use the thresholds to be able to distinguish between progression, mixed progression, and pseudoprogression. In terms of the role of fluocyclin imaging in delineation of tumor extent beyond signal abnormality, there is already literature from this study that's published from Japan that they showed that in 26 patients that they had, all of them had fluocyclin uptake beyond what they could see on contrast enhanced MR. This actually was also consistent with our experience that in some of our patients, we saw signal abnormality beyond what we saw on MR. It's a multifocal GBM that you can see that the bulk of the tumor is in the right posterior temporal lobe. However, there's a very faint MR signal abnormality, faint enhancement, a little bit of flare. When we look at the PET imaging, the extent of the uptake on PET is well beyond what we see on MRI. Another patient that on our study that we see the bulk of the tumor, large nodule kind of abutting the midbrain. But when we look at PET imaging, we see in addition to this nodule, there is another smaller nodule medially, which we can't really see on MR, not even enhances. Flare may be something, but not clear. The patient underwent partial resection, and eventually, after a few months, we saw that the tumor is kind of growing and progressing in the direction of the nodule that was seen on PET a few months ago, indicating that there is a potential for early tumor recurrence detection, or at least the projection and the location of future recurrence on MR can be predicted by PET. But this is just an anecdotal case. So I'm going to skip these in the interest of time and focus on two clinical trials that we have at Children's Hospital using fluocyclin PET imaging. One of them is in high grade to differentiate progression from pseudoprogression. The other one is in low grade glioma to assess the response to targeted therapy or chemotherapy. Both of them are recruiting. This is one of our patients with diffuse midline glioma. And we can see very nice uptake in the tumor, very low uptake in the brain. And this shows the SUV max, and this is the normal brain. So this is a study that we're recruiting. So hopefully we'll have some preliminary data to show in future meetings. And I think that I'm going to also introduce some of the studies in fluocyclin in brain metastasis. This is a small study that's published from Cleveland Clinic, and they showed that using fluocyclin, they can differentiate between treatment changes and recurrent brain metastasis. This patient on top row shows this lesion, which turned out to be radiation necrosis compared to the bottom row, which is a smaller lesion but much higher uptake. Turned out to be tumor progression. They actually showed that the SUV max got up to 4.3, which is not that different from our SUV max from our study. It was able to differentiate these two entities. And these are two clinical trials that are finished recruitment in US using fluocyclin imaging in brain metastasis, the PURSUE and the REVELATE trials. And this is the initial result from PURSUE that included 7 US sites, and UPenn was also one of the US sites. And they actually showed that the SUV max greater or equal to 4.8 can differentiate true tumor recurrence from radiation necrosis. And with that, I think I'm going to conclude by indicating that amino acid PET imaging has been increasingly used in neuro-oncologic imaging. One limitation to widespread use has been the lack of FDA approval and reimbursement, and there has been some successful centers like the Kettering Health and St. Jude that have been able to kind of use as expanded access, but that has been an exception rather than a rule. So hopefully with the FDA approval coming in the next few years, there will be more widespread use of amino acid PET imaging in US to better care for patients with glioma. And with that, I would like to thank the audience and the organizers for inviting me. Thank you.
Okay, thank you so much, Dr. Arif and your team, for very illuminating and very comprehensive talks on the role of PET imaging in neuro-oncology. So the session is now open for questions and answers. Anybody?
All the presentations were very nice, very elaborative, and very much informative, and I'm sure we all learned a lot by such a nice and informative presentations. One question I would like to ask from Dr. Peter. One of your slides, there is an image of brain tumor on MRI, and the tumor size is appears larger on PET image as compared to the MRI image. What I would like to ask from your experience, from where you cut the tumor, do you depend on the PET image size of the tumor regarding, or while you are operating and looking directly on the lesion and you can differentiate directly this is normal brain or this is tumor size? What is your experience, please, kindly?
Thank you for the question. Yeah, that's a very technical aspect here. When we resect the tumors that are that show contrast enhancement, where there is a breakdown of the blood-brain barrier, contrast leaking in, necrosis center, those are very easy to distinguish from a normal brain. So the contrast enhanced portion, I can always tell the difference whether that's normal brain or abnormal brain. Once we start going into the PET active, especially in this particular case that I showed, this was my last week case, very vivid in my mind. The actual consistency. So if I were to describe it on the intraoperatively, the area of necrosis or the area of abnormality as seen on a contrast enhanced MRI, it looks kind of grayish, necrotic, irregular. Then when we go into the margins of the flare signal, which correlates and extends past it with the PET scan, that area of the brain has a bit of a kind of a softer, suckable feeling. You can definitely detect the difference in the normal brain versus abnormal in that case there. Now, it's not always the same. Obviously, there are some more dense area where you go into the deeper portions, white versus gray matter, and not always you have a luxury of very good sort of view. This one is more superficial, so you can kind of tell. But oftentimes it looks and feels normal. However, you're kind of still taking out the tissue because you know that it's abnormal on a PET scan. However, in the appearance of that, it just feels like you're taking a normal brain. So that's kind of how it is. So it all depends on amount of fluid, amount of swelling, amount of edema. And if the flare signal very closely correlates with the PET scan, you will feel a bit of a softer tissue, but it is very unreliable. So going simply by the appearance or by the view and the feel, it varies, and it's not reliable. So therefore, what I do is I basically then mark it using the anatomy. So once I open the craniotomy, I try to incorporate all of that PET images or PET density of, into my surgical field, I mark it with the special marker, and then even if it feels normal, I still go in and resect it. I trust the PET image and PET guidance. If it's an area where I can resect it, I would resect it, even if it looks and feels normal.
Right, thank you. One more question, please. Difference between necrosis and recurrence of tumor. In one of your slides, you showed that on MRI, there seems to be necrosis, but on performing PET image, there was a small nodule which was a recurrence. So what should be normal protocol if we find MRI, only necrosis on MRI, and there is no other symptoms? Should we also do PET MRI, PET CT or PET image to look for a recurrence, or just we should rely on MRI? If it is just necrosis on contrast image, we should stop further, don't go further ahead. Or we should also try to find out just like a small nodule as you showed in one of your images. What should be the protocol? What you would do?
Perfect. So we do have a protocol established. Whenever we have a questionable tumor necrosis, in my practice, I always use PET scan, because it is the MRI appearance is very unreliable. So whenever there I see whenever I question, is it a scar, is it a necrosis, is it a recurrence, as my protocol, and which we have already established here, the PET images comes into play always, and that's how we would confirm. If it confirms to be necrosis and there is no metabolically active center from the PET scan, then we will implement medical management, treatment, surveillance. If there is any suggestion of recurrence, we'll go for it. So I think anytime there is a question or suspicious or question raised by radiologists whether there is a necrosis, we automatically suspect that within that necrosis there can be an active lesion, and it's that until proven otherwise using PET.
Okay, so we can take a couple of more questions.
Thank
Anybody?
you. Thank you very much. I am Dr. Fida, and I have a question from Dr. Ali. You are talking about the fluciclovin. This is basically FDA approved amino acid for recurrent prostate CA. I am wondering, in cases of male adult, if PET scan is done and there is uptake in the brain, how you could say it is a primary brain tumor or it is a metastatic from the prostate? Thank you.
That's a great question. So, amino acid increased expression is not specific to any cancer. It is shown in many cancers, including prostate cancer, meningiomas, and gliomas. So I think that if a patient with prostate cancer, we do fluciclovin PET imaging whole body and we see uptake in the brain, then we need to do dedicated imaging of the brain with MR, and then to see what is the pattern. Is it just a single lesion or multiple lesions, and what are the imaging findings kind of point us to whether this is a metastasis or a glioma. So I think that this is something that is not uncommonly seen, but I think that if we look at the constellation of the patient history and metastatic burden, and also the imaging finding in the brain with PET and MR, usually we can get the answer. There has been quite a few case reports published on this, on meningiomas, that they incidentally were discovered, but then once they did MR, it was clear that this is an extraaxial lesion. And then the distinction between meningioma and metastasis, again, we can get help from other techniques such as somatostatin receptor imaging, which are very high in meningiomas compared to prostate cancer. So I think that this is something that we need to problem solve, but it would be feasible.
Okay, is that all? Shall we proceed to the next speaker? Okay, thank you once again, Dr. Arif Sheikh, Dr. Peter Bouz, Dr. Martin Sitar, and Dr. Ali Nabavizadeh for sharing your knowledge and experience with us, and particularly on a weekend for sparing your precious time.